Today we'll talk about malignant bone tumors. The first is giant cell tumor. So after epiphyseal fusion, there is an eccentric painless swelling which may later become painful, which is fixed to metaphysio-epiphyseal end of a long bone towards the knee and away from the elbow. That means lower end of femur, upper end of tibia, and lower end of radius and upper end of humerus. On examination, there may be eggshell crackling. The appearance of pain and tenderness and angry look. That means red, hot, swollen, tender, loss of function, or evidence of metastasis in the lymph node or by bloodstream into bone or lung indicates conversion to malignancy. Radiologically, you get a soap bubble appearance, and in the X-ray, you must look for break in the cortex, which suggests soft tissue involvement and recurrence, increased chances of recurrence. So here you see a swelling in the lower end of the lateral condyle, which is radiolucent, where you have the soap bubble appearance and which is involving both the metaphysis and the epiphysis, and where you can see a break in the cortex and some involvement of the soft tissue here. Here you see a swelling away from the elbow, lower end of radius. You must take an X-ray of the chest and examine the draining lymph nodes to rule out metastasis. If one of them is enlarged, you must do aspiration cytology. Alkaline phosphatase may be raised, but that doesn't make much of a difference. Histology shows typically the tumor giant cells, but these cells are not the malignant cells. They are defensive or reactive to the malignant cells. So more the giant cells, less malignant is the tumor. These are the giant cells. These are the giant cells. These are the giant cells, these ones. Multiple nuclei distributed all over the cytoplasm, 10 to 20 in number. And these are the tumor cells. Giant cells are reactive to these tumor cells, and more the number of giant cells, less malignant the tumor. Treatment is curettage and bone grafting if it is not excisable. If it is excisable, you excise it. Prevention of recurrence with curettage and bone grafting can be by cryocoagulation using liquid nitrogen, using a burr plus cement, and addition of denosumab, which is against anti-osteoclastic activity. If it is excisable, you excise it. You may only excise it, or you may need reconstruction. You can reconstruct by a fibular graft, for example, in the lower end of radius. In the knee, you can section the anterior half of the lower end of femur in the coronal plane, reverse it, and fill the gap that is created out of excising the tumor in the upper end of tibia. So this is called as reversal bone grafting. You can plate this to the remaining tibia. Then you may use a custom-made prosthesis, and you may also excise the tumor, sterilize it by radiation, and reimplant it. So remove, radiate, and put it back. Advantage is that there are no malignant cells, but all their antigens are available to the body to develop immunity against. So it's this radiation and reimplantation is also a form of immunotherapy. Then if it is there's a malignant transformation which is expedited by irradiation. So there was a person who said that irradiation increases risk of malignant transformation in giant cell tumor, and this should be treated like osteosarcoma. Now we go on to osteosarcoma. Clinically, an adolescent male with red hot, swollen, tender, angry looking metaphysio-epiphyseal swelling from the long bone near the knee and away from the elbow. The difference is that this tumor is circumferential. Giant cell tumor is eccentric. That's the difference. On examination, there are prominent veins, angry look, red hot, swollen, tender, loss of function. Circumferential, not eccentric, unlike the giant cell tumor. And you must look for metastasis in lung. That means you must do an X-ray of the chest. But a far earlier test of detection of secondaries is 4 times increase in the urinary hydroxyprotein levels. This occurs about 7 months before the metastasis appears in the chest. And therefore, this was responsible for change of the regimen, which was the Stanford Cade regimen, that means radiotherapy and ablation, to chemotherapy, ablation, and chemotherapy. Alkaline phosphatase may be raised, and this urinary hydroxyproline is an important investigation. Histology, first you describe the cell, which are fusiform cells with large nuclei showing anaplasia, which means dedifferentiation, mitotic figures. The dedifferentiation component can be bone destruction, hemorrhage necrosis, new bone formation, and enhanced vascularity. This dedifferentiation can lead to cartilage, giant cells, fibrous tissue. That means it can form any sort of bone. This is an example of dedifferentiation. Here, see here, see here, see here, see here, all different types of cells. On X-ray, it is a metaphysio-epiphyseal swelling from the lower end of fibula. You see a triangle here. You see triangular rays in the periosteum here, which is called as the Codman's triangle. You see the sunburst appearance. You see new bone formation and bone destruction. And you also see a soft tissue swelling. So these are the X-ray features of osteosarcoma. Treatment is chemotherapy, ablate, followed by chemotherapy. On day 1, you give vincristine methotrexate, VM. On day 4, cyclophosphamide, cisplatinum or adriamycin. Ablate on day 9 and repeat the cycle 3 weekly for 8+ months. Now, vincristine is 1.4 milligram per meter square, methotrexate 12 to 20 grams per meter square, and you have to use leucovorin rescue. That means 10 milligram per meter square of leucovorin rescue. Then the basic advice is not cisplatinum, not cyclophosphamide, but adriamycin, which is 60 milligrams per meter square. 60 milligram per kilogram is cyclophosphamide, which you can use for poorer patients. Now, since everybody is in the Ayushman cover, so you can use, thanks to Modi ji, so you can use adriamycin. Ablation is amputation or limb preservation. Now, 80% people qualify for limb preservation because of advances. The most important component is wide resection. At least 3 centimeters of tissue impermeable to malignancy should be around the tumor. CT scan, PET scan, MRI have made it easy to define the extent of tumor more clearly. You reconstruct by a custom-made prosthesis, by an allograft, or you resect the segment and sterilize it by heat or irradiation and then reimplant it. Advantage of irradiating and reimplanting is that it exposes the intracellular and the surface antigens of the malignant cell to immunity, and there is an immune response against the tumor which is elsewhere. So interferon is also a thing which is used for immunotherapy. Now, how do you judge prognosis? What are the important events? Death, recurrence, metastasis. So survival without recurrence and metastasis is called as tumor-free survival or TFS. So there may be survival, there may be tumor-free survival, there may be when recurrence occurred, when metastasis occurred. All these are time-dependent events, and this is how you chart the time. Here on this axis you have 1 year, then 2 years, then 3 years, then 4 years, right up to 5 or 6 years, okay? So you start with 100 patients at this point, and you say at 1 year how many were alive? So 90 were alive. So the probability of dying in the first year is 10 upon 100, and the probability of surviving the first year is 90 upon 100. 90% survive the first year. So this way you go on charting what percentage of people who entered the second year survived the second year, the third year, the fourth year, the fifth year, the sixth year. So this way. And this probability of survival makes a curve which is called as the Kaplan-Meier survival curve, because here you are observing at fixed times, 1 year, 2 year, 3 year, 4 year, 5 year, 6 year. But from the beginning to the end of the first year, this curve can be converted into curve like this. Small drops when actual events occurred. So it has to reach from this point to this point. So this curve with small events is called as actuarial survival curve. So you have understood the difference between Kaplan-Meier survival curve and actuarial survival curve. The second thing that you have to understand is how many people survived, this many people died, this many people died, this many people survived the fifth year. This many people survived this fifth year. So 55% survived post 5 years. This is called as 5-year survival. The second measure is 50% of people survived what time? Here it comes out to be 6 years. So the median survival is 6 years. 5-year survival is that at the end of the fifth year, what percentage of people were alive? And median survival is at what time the survivors dropped below 50%. So you have to remember median survival and you have to remember 5-year survival. Understand median survival and 5-year survival. Understand Kaplan-Meier curve and actuarial survival curve. All right. So this is what you understand by this difficult chart. And all these events, survived, tumor-free survival, recurrence or metastasis, can be charted by this Kaplan-Meier or actuarial survival curve. Okay. So as far as osteosarcoma is concerned, 5-year survival with this best treatment is about 65%. If you don't treat, it is about 10%. So I have said that there are two types of survival curves, the fixed time ones and those that record the difference between these 2 points. So they are actuarial survivals. So you have done these actuarial survival and Kaplan-Meier survival curves, and now you try to compare two survival curves. Supposing one person was getting this green treatment, and the other was getting the white treatment, and there were 100 of them. So let us say 20 died in the first year in the white one, but 30 died in the first year in the green one. This can be denoted in the just 2x2 table. This is white, this is green, this is the green one. And 80 were alive and 20 died with the white, but 70 were alive and 30 died in the green. So if you want to compare the two curves at this point, at the first year end, then 20 out of 100 white, 30 out of 100 green. The relative is divide this by this. 20 upon 100 divided by 30 upon 100 is equal to 2 by 3, 66%. So you can say that if you are in the white group, you have 66% greater chances. 66 will die in the first year in the white group and 100 will die in the green group. So relative to the green group, only 66 will die. 100 will die in the green and only 66 will die in the white. So that is the first year. Then you go on calculating this for the second, third, fourth and fifth year. And then you can give a summary of these, which is called as relative probability of dying or relative odds of dying adjusted over time. So this, if it is odds, it is called as the Mantel-Hansel relative risk or Mantel-Hansel odds. Whenever you use Mantel-Hansel, it means that they are adjusted over time. Mantel-Hansel adjusted over time. But you see, this green and white is only differentiating treatment type. But there may be other factors which may be determining survival, like age, like grade of tumor, like type of treatment, right? Like duration at which the treatment was started, how old was the tumor, and like tumor type. So there may be multiple determinants of the event of death, recurrence, survival, metastasis, whatever. So these multiple determinants, when they are there, then you have to use multiple regression. And this multiple regression is called as the Cox proportionate hazard model. The model is like this. Probability of dying or surviving is equal to some number which is called as beta 0. Some number which the model gives you, which is called as beta 0, plus beta 1 x1 plus beta 2 x2 plus beta 3 x3 right up to beta n xn. Now xn here may be age, x2 may be the treatment type, x3 may be the grade. And this number beta 1 or beta 2 or beta 3 is the association between age and the probability of dying or surviving, keeping all other factors constant. So this beta 1, the exponential of beta 1 is odds ratio, is the association between age and probability of dying or surviving, adjusted for all these factors that have been put on the right side of the equation. So this will tell you the strength of association and its p-value. There will always be a p-value given with this beta. The significance of association between x1 and probability of dying with factors x2 to xn held constant. I hope you understand this. Why is it so important to understand the statistics? Because these are the questions in the NEET and the USMLE that differentiate you from the rest. So we are forced to teach you this because you have to give the NEET or the USMLE. You are most welcome to ask again and again till you understand these facts. Now we go on to Ewing sarcoma. The clinical picture, a child with painful fusiform swelling from diaphysis, with angry look, growing rapidly, not responding to antibiotics. Not responding to antibiotics means infection is not there. Infection, fracture. Infection and injury are the most important differential diagnosis initially. Then secondaries from neuroblastoma and reticulum cell sarcoma are the differential diagnosis which are by histology. So this child presents with a painful fusiform swelling from the diaphysis with angry look, growing rapidly, not responding to antibiotics. And see, the difference is fusiform and diaphysis from osteosarcoma. So it is fusiform, means it is longer than broader. It is osteosarcoma is circumferential, osteoclastoma is eccentric. And this is osteosarcoma and giant cell tumor are metaphysio-epiphyseal. This is from the diaphysis. They are after epiphyseal fusion. This is occurring in a child. So after this differentiation, you take an X-ray. And what you see here are these layers of like onion peel. You seal this onion peel, and this indicates a this onion peel indicates a Ewing sarcoma. Diaphysis, child, angry look, longer than broader, onion peel appearance, and this is Ewing sarcoma. Histopathology may be a liquid consistency and may mimic pus. There are sheets of monotonous small round blue cells. See these cells here. And they are trying to form circles. So they are trying to form glands. Okay. So this is called as the pseudo rosette appearance. Circle of cells with necrosis in the center. Treatment, chemotherapy. Now, two types of chemotherapy, induction and maintenance. The induction is by BCD-VMA, bleomycin, cyclophosphamide, dactynomycin. Cyclophosphamide can be replaced by cisplatin. And in the induction, you combine them with vincristine, methotrexate, adriamycin. And this is called as T2 induction. And then you maintain it by vincristine, methotrexate, adriamycin. This is called as T6 maintenance. Now this is what has been recommended in the book by Rosen, and is the practice in the Sloan Kettering Memorial Center in New York. So this is what is there, and it is able to give you 70 or 5-year survival. Chondrosarcoma, we have dealt with benign tumors. Fibrosarcoma also we dealt with benign tumors. Now we go on to multiple myeloma, which is one of the tumors involving multiple bones and occurring in elderly. Here I would like you to concentrate on a B lymphocyte. This is the B lymphocyte. Big nucleus, scant cytoplasm. This converts into plasma cells. Now you see the cytoplasm has increased. The nucleus shows a cartwheel structure. There is the cytoplasm is granular except at a place which is called as the myeloma body or the Anner body. This Anner body is filled with immunoglobulins, which may be IgG, MADE, and these immunoglobulins will be secreted in the bloodstream. So this is the B lymphocytes, this is the cartwheel nucleus, this is the Anner or the myeloma body. And if you see more than 10 cells in high power microscopic field in the marrow, then it is diagnostic of multiple myeloma. On X-ray, you see these punched out areas in the bone, and clinically, there is pain and tenderness in multiple bones. Some of them may fracture, that pathological fracture. So when the marrow is replaced by these multiple myeloma or plasma cells, it results in pancytopenia. Pancytopenia means RBC, WBC, platelets less. So anemia, leukopenia, opportunistic infections and platelet. Sometimes this multiple myeloma is not multiple. It can occur at single place when it is called as plasmocytoma. And sometimes this multiple myeloma can lead to lymphocytes in the bloodstream also. There it is called as plasma cell leukemia. or lymphocytic leukemia, acute or chronic. So now we have dealt with pancytopenia, anemia, pancytopenia, and deficiency of platelets can cause thrombocytopenia and bleeding tendency, which is called as purpura. Then from bone, these immunoglobulins are secreted into blood. So there may be a raised ESR, altered AG albumin globulin ratio. This is altered, and you may get, if you do a radial immunodiffusion, you may show increased IgG, M, A, D or E, any of these antibodies. And finally, you will see, if you do a protein electrophoresis, you may see a band where the immunoglobulin band should be, and this is called as the myeloma band. Now, liver converts these immunoglobulins to uric acid, so serum uric acid may be raised, and you may get gout or uric acid stones in the kidney. And these immunoglobulins may combine with glycosaminoglycans. And when they combine, they form amyloid. And this amyloid may deposit in many areas, including the kidney. First, the kidney becomes leaky, nephrotic syndrome, and then it fails, renal failure. Treatment is excellent response to cyclophosphamide. If doesn't respond to this, you can give busulfan. Recently, lots of non-chemotherapeutic agents, molecules which can help, and they include tyrosine kinase inhibitors like ibrutinib. They prevent multiplication of B cells and increase apoptosis. Now we go on to the secondaries. The follicular carcinoma from the thyroid. We begin up from the neck, thyroid. It metastasizes in bone. If you remove the thyroid, the secondary will subside. That's why it is called as Krokenberg tumor. And after removing the thyroid, if you give radioactive iodine, all that radioactive iodine will go to the secondary and will improve the prognosis, because the thyroid tissue is not competing with the malignant tissue. So these tumors are called as Krokenberg tumors. Then from the thyroid we descend to breast and lung. Nothing much to say here. Then to suprarenal is neuroblastoma. This can secrete catecholamines. Adrenal gland secretes catecholamines, which may cause increased BP, and they are secreted in urine as vinyl mandelic acid of VMA. So, in bouts of increased blood pressure where they should not be, and vinyl mandelic acid in urine is indicative of a neuroblastoma. It metastasizes in flat bones. If you remove the primary, the secondary subsides, the Krokenberg's tumors. Histologically, this neuroblastoma and reticulum sarcoma are differential diagnoses of Ewing sarcoma. Reticulum sarcoma can be diagnosed by reticulin stain positivity. This tumor can also metastasize in the orbit, can produce proptosis. Kidney hypernephroma is treated by nephrectomy. Again, secondary will subside if you remove the primary. Also, this is the only tumor where, because the tumor produces erythropoietin, hemoglobin may increase, and this is called as polycythemic response, polycythemia response. So normally hemoglobin should be low, but if you are finding it high, it may indicate hypernephroma. Prostate means prostate specific antigen is increased. The groove in the posterior part of prostate in per rectal examination disappears. Acid phosphatase may rise. Treatment is by orchidectomy or medical orchidectomy by giving drugs which block testosterone synthesis. Osteosclerotic secondaries are seen. Osteosclerotic secondaries and raised acid phosphatase, increased PSA titer. These are three diagnostic features of prostate cancer. And this is an example of an osteosclerotic secondary. See here, see here. Whenever you see this, you think of secondaries from prostate. Thank you.